Hello everybody, this is Dr. Pruett. Today we're going to be talking about chest trauma while we're continuing our trauma series this month. It is important to note that 25% of traumatic deaths involve chest trauma, and that's not surprising when you consider all the vital organs that are located in the chest and how those, if they were injured, could lead to fatalities. Now, it's important to think about when we have patients experiencing chest trauma. If you see a patient who is in respiratory distress and is in shock, this is a 75% mortality. So if you can identify those things early in your trauma patients, you want to load them and get them to the hospital as quickly as you can, because this is not an area of the body where we have any control over hemorrhage or injury prevention. As we mentioned, there's 5 very important structures in the chest. This is the trachea, the esophagus, both lungs, the heart, and all of the great vessels coming off of the heart supplying blood to the body. Very important area. And you can tell that it's important because the way that the body is designed, it's very well protected by bony structures. If you were just to look at the skeleton, you could surmise that everything underneath that rib cage is probably very important to survival. And it's been that way and needs to be protected. One of my favorite things about anatomy is the way the bony structure protects the underlying organs. And if you look, this is called the sternal angle of Louis right here. And if this bone is called the manubrium, and it's right on top of the sternum. And if you look where this is located and you look at what's directly underneath it, it's pretty amazing how our body is able to protect these structures. Because right underneath the sternal angle of Louis is the left ventricle of the heart that's coming out with the aorta right here. It's protecting the majority of the trachea that's exposed. It's also protecting the great vessels that go left and go right, and the major parts of the lungs as well. So our body is very creatively designed in the fact that these bony structures are protecting the most important parts while still allowing for expansion and movement of our upper extremities with the ribs. If you look at the rib cage from the side, the way that the heart is suspended in the chest, this is an important point here because later when we talk about perpendicular impact and impact from the side, you can see that the chest is way more protected from the anterior-posterior direction than it is from a lateral impact, where the heart is kind of suspended in the chest here between the backbone and the sternum. If you had an impact from the side, you can see how it's just kind of hanging there like a pendulum from the great vessels. So again, if we review the 5 places to bleed to death, we know we can bleed to death in the street, the femur, the pelvis, the chest, and the abdomen. The femur, extremity hemorrhage, and pelvis are all areas where we know how to control these hemorrhages. The chest and the abdomen are areas where these are going to require surgical intervention. So just like any trauma, there's 2 kinds. We have penetrating and blunt trauma. We can divide them into 2 categories and kind of base our care and our suspected underlying injuries off of these different mechanisms. So penetrating chest trauma here in Albuquerque, we know our most common are stabbings and shootings. It's important that we remember not to remove any foreign bodies that are embedded, because this might actually be occluding and tamponading any vessels, and if removed might worsen bleeding. Penetrating injuries frequently will cause what we term sucking chest wounds or open pneumothorax. And you'll see, I know police do it a lot here, but occlusive dressings being placed with the dressing being secured on 3 sides with one side open for air to escape. Now, the reason that we do this is if you think about a penetrating injury to the chest, you have your lung here, and usually it slides right up against the rib cage. But if there's a way, say a gunshot wound, for air to get in from the outside, as this patient takes a deep breath, air is going to come in through the trachea like normal, but it's also going to come in through that sucking chest wound on the periphery of the chest. And that air that's coming in isn't going to go into the lung and isn't going to help with oxygenation. What it's going to do is build up pressure inside the chest and cause that lung to collapse. And so by placing a chest seal, what you're doing is every time that patient takes a deep breath in, you're preventing air from getting in the hole. And preventing air from getting in the hole is going to prevent that lung from collapsing too fast. But what it also does by leaving that fourth space open and only securing your dressing on 3 sides is that as that patient exhales, you're going to allow air to escape, again, trying to prevent this lung from collapsing. When we think about treatment for penetrating chest trauma, as a BLS provider, what you can do most importantly is manage that airway, provide supplemental oxygen, do a LMA or bag if you need to, and load them and get ready to go. From an ALS perspective, it's going to be very important to monitor for tension pneumothorax. It's safe to assume that with a penetrating chest injury, this patient likely has a pneumothorax, but we're going to not intervene until we see tension physiology. Also, as an ALS or even an intermediate, you can obtain IV access and help treat that hypotension and shock by aiming for permissive hypotension. Really, like we talked about with those 5 areas of bleeding, what these patients need is a surgeon, and so the best thing that anybody can do for them is get them to the hospital quickly. When we think about pneumothorax, it's much like I just explained with that penetrating injury and why we use occlusive dressings in sucking chest wounds, but you don't necessarily have to have a sucking chest wound to cause a pneumothorax. For whatever reason, in chest trauma, say blunt trauma or penetrating trauma, the lung, just like you would pop a plastic bag, can pop. And as that patient takes a deep breath in, air can escape and collect between the lung and the periphery of the chest. And the more air that escapes and the faster that air escapes, it's going to cause more and more pressure in the chest and start to collapse that spongy lung to where there's less and less room for the lung to provide oxygen and exhale carbon dioxide. Now that's a simple pneumothorax, and we see those a lot. The treatment for simple pneumothorax is simply high flow oxygen and getting them to a hospital. When this becomes a life-threatening situation is when the patient develops tension pneumothorax. And it's the same thing. We have a punctured lung for whatever reason. Maybe it's a penetrating chest injury. Maybe the lung just had a sudden explosive force that caused it to pop. For whatever reason, pressure's building up inside the chest. And when we develop tension pneumothorax, what's happening is as that air builds up, it builds up more and more and more to the place where the lung is completely collapsed. And as that pressure still continues to increase, it moves the heart over to the opposite side of the chest. And we call that mediastinal shift. And why that's bad is because it all comes down to the right side of the heart. The right side of the heart is fed by venous circulation and is under very low pressures. And so as that heart starts to move from its anatomical position, the superior vena cava and the inferior vena cava can kink and basically occlude themselves. And what that does is it leaves no room for blood to return to the heart. And if the heart's not getting any blood, you go to instant obstructive shock. Now here's what it looks like on an x-ray. You can see here this patient was shot in the chest. What's happening here is just like we saw in the previous illustrations, there's air building up in the chest from the penetrating injury. Likely over here you can see the air in the skin over here. That would be subcutaneous emphysema. The air is building up in the chest. It has collapsed the lung to about half of where it should be. It's pushing the lung over in the chest, but not only that, this is a tension pneumothorax because it's moved the heart from the left side of the body where it should be to the right side of the body. And you can also start to see the tracheal deviation here as well. So what's the difference between a simple pneumothorax and a tension pneumothorax? In a tension pneumothorax, your patient is going to have all the signs and symptoms of obstructive shock. A simple pneumothorax won't necessarily cause those signs and symptoms. So when we think about obstructive shock, the signs and the symptoms that we look for are a low blood pressure. The patient will be tachycardic and short of breath with a very weak pulse and sweaty skin. Now, if you look at most of these signs and symptoms, these are the signs and symptoms of any kind of shock. So it doesn't necessarily mean that they have a tension pneumothorax unless you're super suspicious of the mechanism. This patient, remember, this is a trauma patient, so it could just be plain old hemorrhagic shock as well. But what's happening in any shock is cardiac output is affected. And remember that the two factors that go into cardiac output are heart rate and stroke volume. Well, heart rate is going to be high, right? Because it's trying to tell that heart needs to beat faster because the organs aren't getting all the oxygen delivery they need. But in obstructive shock, what's happening, like we just talked about, is these vessels are tamponaded off by the fact that the heart has shifted in the chest. So there's either not enough volume getting to the blood and not a way for the heart to increase stroke volume because blood cannot physically get back to the heart. So one of the signs that we'll see in patients with obstructive shock is jugular venous distension. Now, this isn't a super reliable thing in patients with attention pneumothorax because your patient also might be bleeding somewhere. So if they're volume depleted or they're hypovolemic or also in hemorrhagic shock, they might not have enough blood volume to back up, but this is one thing that I would look for in their neck, because as blood from the superior vena cava is obstructed from getting into that right atrial chamber to be pumped out, it's going to back up and it's going to cause distension of those jugular veins. The way that we treat tension pneumothorax is with needle decompression, and I know you all know this, but we either go in the second intercostal space in the midclavicular line, or you can go in the fourth or fifth mid-axillary space right above the rib. And the reason we go right above the rib is if you look at the anatomy, every rib has an associated neurovascular bundle right below it. So there's a vein, an artery, and a nerve right below each rib. And so if you go right over the rib that you're aiming for, you'll miss that neurovascular bundle and minimize that patient's bleeding. And the idea there is to give that air that's in the chest a chance to escape from the chest and give that lung a chance to reinflate. So we already talked about placement. There's that second intercostal space in the midclavicular line. Or in the mid-axillary line, you can go in that fourth or fifth intercostal space right above that rib. Now, it's really important to note here on these mid-axillary approaches that on a male, you want to be right about the nipple line, right at the base of the armpit. If you go much lower than that at a patient that's breathing very shallowly, your spleen on the left and your liver on the right are a lot higher than you think. So it's better to go closer to the armpit than farther down, because you don't want to cause an intra-abdominal injury. Now remember that if you're going to do a needle decompression, your indications for that are obstructive shock. So hypotension is going to be your most specific finding. If you have a hypoxic, hypotensive patient with a mechanism to cause a tension pneumothorax, that is a patient who needs a needle decompression. Look for the JVD, realizing that it may or may not be there depending on the volume status of your patient. And also if you hear absent lung sounds on one side that's asymmetric with the opposite side, and a patient that's severely short of breath, that's also likely a patient that needs it. When you're documenting these things, I want to see as many of these indicators as possible. So hypotension, absent lung sounds, hypoxia, tachycardia, and a patient that's short of breath are things I expect to see. Now there's other mechanisms that can cause obstructive shock. Another one relating to chest trauma would be cardiac tamponade. Now the heart sits in the chest. It's in a very firm fibrous sac, and it's called the pericardial sac. And sometimes, depending on the vessel that's injured, the sac can fill with blood. And if it fills very quickly, the blood can cause, again, that right ventricular collapse. The right side of the heart is very weak and can't sustain much pressure. And so if the sac around the heart tends to fill with blood or fluid, it collapses that right side. And again, just like we had with the tension pneumothorax, it makes it where the right side of the heart can't fill and can't get blood to the lungs. So your patient will be short of breath and also have signs and symptoms of obstructive shock. Now this is just another diagram of what it might look like as that sac fills with blood. You can see it starts to compress that right ventricle, and that wall is so weak on the right side that it can't push back and can't get blood to the lungs. This is what it looks like on a CAT scan. Here you have the patient's left side of the chest and the right side of the chest with the right lung. Here's the heart, but it's surrounded by blood, and you can see here on the right side of the heart how it's caved in right there, and it's collapsing under the pressure from all the blood that's filling up in the sac there. Now both tension pneumothorax and cardiac tamponade are going to cause obstructive shock. Well, if you can tell that your patient is in shock, but you just don't know which one, how are you going to tell the difference? The easiest way is by auscultation. So your patient with a tension pneumothorax is going to have absent lung sounds, where your patient with a cardiac tamponade is going to have either absent or very, very muffled or difficult to hear heart tones. Now, I know that's difficult to ascertain in the back of an ambulance, but it's something that you can try. Moving on from penetrating to blunt trauma, this is something that we see very frequently. Mostly here in the city, it's either pedestrian versus automobile or some kind of car accident. But don't forget our outdoor adventurists that tend to hurt themselves as well. Importantly, when we're talking about blunt trauma, kinetics is a huge factor in this. So going back to our physics, kinetic injury is related to mass and velocity, right? If you look at the factors in this equation, mass is much less of an important factor than velocity is. Velocity is actually squared, where it's half of the mass. So whether it's a motorcycle or whether it's a car, doesn't really matter. What matters is how fast they're going. And the other important factor here is all of that energy, however much it is, that goes into that car when it hits the light pole, all of that energy is also transferred to the patient who's in that car. So however many kilojoules of energy this is when this car hit the pole is the same amount of kilojoules of energy that hit this chest when the patient hit the steering wheel if they were unrestrained. These are massive amounts of forces and very important to remember when we're treating our patients. One thing that we can look for to indicate how much force this patient experienced is a seatbelt sign. Again, you look, good thing that sternal angle of Louis was there, right? That bone really protected all those vital organs. But you can tell extending up into the clavicle, there's a major vessel here and likely some rib fractures over here. So if you see the seatbelt sign, realize that that chest just sustained a very massive impact. And that's a patient with some potentially life-threatening injuries. Even though it looks like a fairly benign abrasion, think about the injury that was underlying that mechanism. So when we talk about rib fractures, again, we have to think about the things that we can't see. So if you have a patient where you suspect rib fractures, realize that underlying those ribs is a lung that's probably been bruised. And on the inferior portion, on each side of the ribs, on the left side, those ribs are protecting a spleen. And on the right side, those ribs are protecting a liver. And so if those bones are broken, just like any bone that breaks, it turns into a little knife. And if that bone is broken to the point where it's moving every time the patient breathes, it can be lacerating that spleen or that liver and causing further abdominal trauma, or lacerating the lung and causing pulmonary hemorrhage or pulmonary contusions. So always think about what's going on underneath the things that you can see on the skin. Pulmonary contusions are basically lung bruising, and there's little tiny hemorrhages, and that can be due to either increased intrathoracic pressure where little capillaries are going to hemorrhage, or it can be due to overlying crushing trauma on the chest. Now, just like any bruise, at least initially, these aren't going to be that impressive, but they develop and they blossom over time to the point where they can cause some pretty significant hypoxia and respiratory distress in patients who experience this. You can see underneath the ribs here, a bruise starts to develop, and this is what it looks like on a CAT scan. It's just increasing bleeding from these capillaries that were ruptured from the direct trauma, and then increasing inflammation coming around to help heal that area. But it leads to pretty significant hypoxia and respiratory distress. This patient, incidentally, also has a small little pneumothorax over here. You can see how the lung is collapsed, and there's black area here with no lung volume. So if you do have rib fractures, just anticipate that there is some underlying lung injury, and also don't be surprised if there's an underlying pneumothorax as well. So treat those patients with supplemental oxygen and good pain control. We've all heard about the flail chest. This is what that looks like. The thing that you're looking for is paradoxical chest rise. Our chest should be coming outwards as we take a deep breath in, but on this patient, the definition of a flail chest is 2 or more ribs broken in 2 or more spaces. So basically, as he breathes in, there's no more rigidity in that chest wall to expand, and it's collapsing in. Now, this patient looks like he's intubated, but if you see this in the field with this paradoxical chest movement, what you want to do is provide positive pressure to help get air into the lungs where it needs to go, and also good pain control. You don't want to add anything heavy to that chest because it's already injured and it's already having enough time expanding to fill those lungs. All you want to do is positive pressure and get them to the hospital. Realizing for that kind of an impact to completely crush the chest like that, he's going to have some very significant underlying chest injuries. Another, when you think back to the bony anatomy of the chest, underlying that sternum and the manubrium at the sternal angle of Louis is the heart. And the heart, just like the lungs, can be bruised, and that's called a cardiac contusion. So if you have a patient who experienced some significant chest trauma, realize that an explosive force to that heart, it's like a little balloon in the chest, and if it gets a sudden impact, there's a lot of damage that can occur. So whether that's a valvular disruption, a vascular disruption that can lead to tamponade, or actually even a STEMI if you lacerate a coronary artery, or even rupture a ventricular wall. Say you've got an older patient that has a very thin wall from a previous MI, it doesn't take a lot of force to rupture that ventricular wall and maybe lead to a cardiac tamponade. Anytime the heart has a contusion or some trauma to it, you can expect arrhythmias to occur. It's going to disrupt that electrical conduction system. So it'd be a good idea to have these patients on the monitor. One thing you hear about in children fairly frequently, here in New Mexico, it's baseball players. Back east, it can be lacrosse players, or up north, maybe hockey. A small, hard object at a high velocity that hits a kid's chest at just the right angle, at just the right time, can instantly put that heart into ventricular fibrillation. This is called Commotio Cordis, and it can take a heart that's beating normally, induce a sudden electrical event if it happens at just the right time with a T wave, and put that patient into ventricular fibrillation. If you see this and it's the right mechanism, you want to treat it as ACLS and get that monitor on and defibrillate it if needed. Another chest injury that can be seen is a tracheal-bronchial injury, and this is where up higher in the chest, if there's some sort of acceleration or deceleration injury where the bronchus actually rips and tears and is no longer able to deliver oxygen directly to the lung, but delivers oxygen into the chest. And this is the patient where you're going to see a lot of subcutaneous emphysema that feels like Rice Krispies when you push on it. And depending on how high the injury is, there's going to be more oxygen flowing into the subcutaneous tissues the closer you are to the trachea. And if you look at this CAT scan here, this is an area where most of the air that patient is breathing in is going into the chest wall and putting more pressure on that chest and not actually getting into the lungs where it needs to go. Now, what's bad about this, just like with tension pneumothorax, is as air builds up in the mediastinum, it increases pressure and it can occlude vessels. Sometimes you'll see patients with a swollen neck and face, and as that air tends to build up in the upper chest, just like the air can build up pressure and occlude vessels, it can also occlude upper airway structures. And so you can see in this patient here, he had something like this, but see how his shoulders look really puffy? I bet if you pushed on his shoulders or his neck right in here, you'd feel that Rice Krispie feeling because of his tracheal-bronchial injury. Air is going to dissect along the path of least resistance, and so there's not much resistance in the face, so that you can see here the air has actually gone all the way up to his eyes and caused them to be swollen because of the air not going to the lungs but into the interstitial spaces in his chest and neck. One of the most fatal things that we think about in traumatic injuries is traumatic aortic disruption, and this is most likely to occur in, say, like a T-bone kind of car wreck where the patient is hit perpendicularly instead of anterior posteriorly, because just like that heart sits as a pendulum in the chest, what can happen with a sudden fierce impact is that the aorta can actually rip. And this can cause either an aortic dissection down the descending aorta, or it can lead to a tamponade kind of picture as blood leaks and dissects into the pericardial sac. Now, most of these patients are going to die before we ever get on scene. If you can imagine, it takes 3 minutes to die from a femoral artery injury. It's going to take even less than that if you have a hole in your aorta. So a lot of times before we get there, these patients will be dead, but sometimes they're not. And so another 30% of these patients with this injury will die within 24 hours of their injury. It's important to think about the mechanism of the trauma that occurred to the chest and make sure you're checking radial pulses to make sure that they're equal, because where the aorta tends to tear is just past the ligamentum arteriosum. So your patient will usually have decreased pulses on the left side, but normal pulses on the right side. Here's what it looks like on CAT scan. You can see an aortic transection here, aortic aneurysm here as blood comes out of the heart. And then here is an aortic dissection that led to a tamponade. So you see the actual heart here, but the blood from the aorta that's dissecting is surrounding the heart here and causing that cardiovascular collapse. Another thing that can happen with a sudden explosive compression of the chest is that remember that low pressure venous system as blood is coming back to the heart on the right side. If you have a force that overcomes that and compresses the chest, it reverses the blood flow of the venous system and forces that blood in the opposite direction and can cause this kind of petechial rash with little punctate hemorrhages of the capillaries in the upper chest and neck and even into the eyes. Usually when you see this, it's a little remarkable and it'll kind of take your breath away and it looks pretty awful, but ultimately once that compressive force is over, blood flow is going to return to normal, and usually there's not a lot to do about this injury. So things that we can do in the field, these are all important things to think about, but really what you want to do is consider that mechanism of injury, recognize these injury patterns, and realize that any trauma to the chest that's significant is probably severe, and there could be some very serious underlying tissue damage, which you're not going to be able to see. So have a high degree of suspicion, give them the supplemental oxygen that they need, and if you have a patient that's in some sort of shock and is short of breath, get them to the hospital as quickly as you can, keep them on the monitor, be ready to decompress that chest and treat their pain. And that's all I have for you. Any questions, please let me know or contact your 7-8.